Welcome to our listeners around the world. We have a special edition of the JAMA Editor's Summary, featuring research published in JAMA and JAMA Cardiology, and presented at this year's American Heart Association Scientific Sessions. I'm JAMA Executive Editor, Dr. Greg Curfman, and I'm joined by JAMA Cardiology Editor-in-Chief, Dr. Bob Bonow, and JAMA Senior Editor, Dr. Phil Greenland. Welcome, everyone. We're going to review 9 papers being presented at the American Heart Association Scientific Sessions. And Phil, I wonder if you could kick off the discussion with a discussion of your first clinical trial.
Thanks, Greg. I'll be discussing a paper called Caffeinated Coffee Consumption or Abstinence to Reduce Atrial Fibrillation, the DECAF randomized clinical trial. The background here is that many patients and clinicians believe that caffeinated coffee increases arrhythmia risk. As we know, coffee is also very commonly consumed. It's the most commonly consumed caffeinated beverage in the United States, and a randomized trial assessing caffeinated coffee consumption in patients with atrial fibrillation had not previously been performed. The goal of this study was to determine the effect of caffeinated coffee consumption compared to abstinence from coffee and caffeine on recurrent atrial fibrillation. The researchers conducted a prospective, open-label, randomized clinical trial that enrolled 200 current or previous, within the last 5 years, coffee-drinking adults with persistent atrial fibrillation or atrial flutter with history of AFib, planned for electrical cardioversion from 5 hospitals in the U.S., Canada, and Australia. Patients were randomized to regular caffeinated coffee consumption versus coffee and caffeine abstinence for 6 months. Patients in the coffee consumption group were encouraged to drink at least 1 cup of caffeinated coffee every day. Patients in the abstinence group were encouraged to completely abstain from coffee and other caffeinated drinks. The primary endpoint was clinically detected recurrence of atrial fibrillation or atrial flutter over 6 months. Baseline coffee intake was 7 cups per week in both groups. During follow-up, coffee intake in the consumption and abstinence group was 7 and 0 respectively per week, resulting in a between-group difference of 7 cups per week. In the primary analysis, atrial fibrillation or flutter recurrence was less in the coffee consumption group compared to the coffee abstinence group, 47% versus 64%, which is a 39% lower hazard of recurrence, and this difference was statistically significant. There were no significant differences in adverse effects. So in this trial that involved random allocation to consumption of caffeinated coffee, averaging 1 cup a day, coffee drinking was actually associated with lower recurrence of atrial fibrillation or flutter compared to abstinence from coffee and caffeinated products. And obviously, this contradicts the general belief that the opposite is the case. We thought this was an important result, and it definitely shows the power of clinical trial evidence compared to anecdotal or observational evidence.
Excellent. Thank you very much, Phil. Very, very interesting paper for sure. Has received a lot of attention at the meeting. Next, I'm going to present a study titled Efficacy and Safety of Oral PCSK9 Inhibitor, Enlicitide, in Adults with Heterozygous Familial Hypercholesterolemia. Now, PCSK9 inhibitors have been an important addition to the armamentarium to lower LDL cholesterol levels. Traditionally, PCSK9 inhibitors have been monoclonal antibodies, and therefore they have required injection. And the uptake of the monoclonal antibody therapies has been somewhat limited, in part because they do require injection. Enlicitide, however, is an oral PCSK9 inhibitor, one of the first to have been developed. And in this clinical trial, about 300 patients with heterozygous familial hypercholesterolemia were randomized to Enlicitide or placebo. They were followed for 24 weeks. The primary endpoint was the mean percentage change in LDL cholesterol levels. And after 24 weeks, there was a 60% reduction in LDL cholesterol in the Enlicitide group corrected for placebo. And in addition, there was a 50% reduction in apolipoprotein B levels. So the authors have concluded that this new oral preparation, a PCSK9 inhibitor, appears to be very effective in lowering LDL levels and, in addition, apolipoprotein B levels. There were no clinical endpoints in this trial. The focus was really on LDL and ApoB. So we felt this was an interesting new approach to lowering LDL levels. And the real advantage here is that this is an oral preparation that does not require injection. So it will be interesting to see if this approach to LDL lowering will have an impact in clinical practice as time goes on. Now, Bob, we'd like to go on with your first paper.
Well, thank you, Greg. We have several interesting papers presented at the AHA meeting this year. One of note is a study on physical activity and cardiovascular outcomes in phenotype-negative carriers of cardiomyopathy variant genes. We're concerned in people who have genetic cardiomyopathies, there may be some risk of intense exercise, either in disease progression and in some cases even the risk of sudden cardiac death. But in people who have the genotypic evidence, so they have the variant for cardiomyopathy but have no phenotypic evidence of the disease, we tend to recommend those individuals could have normal activities, but it's good to have some evidence. And so this paper we thought was interesting by Ajufo and co-authors. This is a multinational authorship group, but driven by the investigators at the Broad Institute and the Brigham and Women's Hospital. They looked at 85,000 individuals in the UK biobank, in whom there was both whole genome sequencing to get the evidence for any genetic variants, as well as 1 week of accelerometer-based physical activity data. So they had data regarding the level of activities in these individuals. Of the 85,000 people, 4,000 individuals were carriers of cardiomyopathic gene variants. They were a mean age of 62, and importantly, 57% were women. And as expected for the total group, those people who had higher levels of activity, moderate to vigorous activity, had significantly less incidence over time of developing atrial fibrillation, heart failure, myocardial infarction, or stroke. That's not novel, but what was novel was that the same findings were seen in the individuals who had the carriers of the cardiomyopathic variants. And indeed, in the variant group, higher levels of activity was also associated with less incidence of evidence of cardiomyopathy over time. This was true for individuals with genes coding for dilated cardiomyopathy, hypertrophic cardiomyopathy, and arrhythmogenic cardiomyopathies as well. So these data were interesting, and they tend to support the appropriateness of the guidelines-based activity recommendations across the board for all people. Now we can probably say this is also the case for those with asymptomatic carriers of cardiomyopathic variant genes.
That's great. Thank you so much, Bob. Phil, let's go on to your interesting paper on the DASH diet and its effects on blood pressure.
So this is also a paper from JAMA. It's called DASH Patterned Groceries and Effects of Blood Pressure. It's the results of a randomized trial called GoFresh, and the first author is Stephen Jurashek. So going back almost 20 years, we know that the dietary approaches to stop hypertension diet, which we call DASH, is an eating plan that has been shown to lower blood pressure in controlled experimental environments, but there have been no studies of grocery shopping strategies that have examined the effects of the dietary approach on blood pressure. So the objective of this study was to conduct a trial in lower-income Black patients to determine the effects of a low-sodium DASH grocery shopping strategy on systolic blood pressure. The trial was a randomized parallel group study done in Boston. They enrolled Black residents from communities that had few grocery stores. The entry-level systolic blood pressure was between 120 and 150 millimeters of mercury. Diastolic blood pressure was less than 100, and the participants were not on prior blood pressure drug treatment. Participants were randomly assigned to one of two strategies, either a 12-week home-delivered, DASH-patterned groceries ordered weekly, along with dietary counseling about what groceries to order. And that particular approach did not emphasize the cost of the groceries. The alternative strategy was to provide 3 $500 stipends every 4 weeks to the other group, which was intended for self-directed grocery shopping. The primary outcome comparison here was difference in 3 months change in office systolic blood pressure, which was taken over multiple visits between the interventions. Secondary outcomes included diabetes, body mass index, hemoglobin A1C, and LDL cholesterol. And the maintenance of the intervention effect was assessed 3 months after the intervention ended. Study eventually involved 180 participants. 97% completed the primary outcome assessment, so the study was very well done. The mean baseline systolic blood pressure and diastolic blood pressure were 130/80. At 3 months, mean systolic blood pressure changed by lowering 5.7 millimeters of mercury among the DASH pattern group and lower 2.3 millimeters mercury among the self-directed group. And that difference, although it was only 3 millimeters of mercury, was a highly significant difference statistically. Compared with the self-directed group, after 3 months, the DASH pattern group also had lower diastolic blood pressure, lower urinary sodium, higher urinary potassium, and slightly lower LDL cholesterol. There were no differences on BMI and hemoglobin A1C. Unfortunately, after the intervention stopped, the blood pressure effect was not maintained. So in summary, this was a program of home-delivered DASH-style groceries plus dietitian counseling, which was associated with reduced blood pressure and LDL cholesterol during the intervention itself, but the effects were not maintained after the intervention. So this trial is important in the sense that it demonstrates the possibility of what we are now calling food as medicine. But given the lack of long-term maintenance, we need to learn more about how to sustain that benefit long-term in participants like those in the study.
Excellent. Thank you so much, Phil. Most interesting. Next, I'm going to present a clinical trial dealing with peripheral artery disease. And the title of this trial is Metformin to improve walking performance in lower extremity peripheral artery disease. This is referred to as the PERMET randomized clinical trial. Of course, we think of metformin as a drug for type 2 diabetes, but it does have pleiotropic effects that include improved endothelial function, reduced oxidative stress, and it also increases endothelial nitric oxide synthase activity. So metformin was studied in this clinical trial to see whether it would improve the 6-minute walk distance in patients with peripheral artery disease. And these are patients who did not have diabetes. The follow-up was 6 months. 200 patients were randomized to metformin or placebo, and the primary endpoint was the change in 6-minute walk distance after 6 months of therapy. This was a negative trial. Metformin did not significantly improve 6-minute walk distance compared with placebo. So why did we decide to publish a negative trial? The treatment of peripheral artery disease, particularly to try to improve functional capacity, in patients who have lower extremity symptoms has been very difficult. This is a very challenging clinical condition, and there are very few therapies that are effective. We felt that it was important to record in the literature another drug that was not effective in this setting, with the hope that this will redirect research into other avenues, and that eventually we will find new therapies that will be effective. So, Bob, let's go on to your next study.
We were very interested in this study by Alexander and co-authors, efficacy of Acoramidis in wild-type and variant transthyretin amyloid cardiomyopathy. Acoramidis is an interesting oral therapy for treating transthyretin cardiomyopathy. It's a near-complete TTR stabilizer, which is now approved for therapy. The attribute cardiomyopathy trial was helpful in getting this drug on the market, and that trial showed that in a placebo-controlled randomized trial that acoramidis led to a reduction in cardiovascular hospitalization and all-cause mortality. This study by Alexander and co-authors is a secondary analysis of that trial, breaking down the patients into those with wild-type TTR cardiomyopathy and variant TTR cardiomyopathy. Patients were followed for 30 months in the randomized trial, and there was also an extension of those individuals who stayed in the trial for up to 42 months. 611 individuals initially in the randomized portion of the trial and 380 in the extension. And what the investigators showed was that independent of whether you had wild type versus variant TTR cardiomyopathy, the results were very similar in terms of reduction in death and reduction in cardiovascular hospitalization. 31% reduction in wild type and up to 59% reduction in variant. But that was not statistically significant, and there was no heterogeneity, presumably because only 10% of the 611 patients actually had a genetic variant that was identified. So we think this is interesting further data on this important drug. Perhaps when we have larger studies of patients with variant cardiomyopathy to see whether indeed there's an added bang for your buck in those individuals would be helpful. But at the current time, I think we can say with certainty that this drug is effective in both forms of TTR cardiomyopathy.
Very interesting, Bob. Thank you so much. And it's interesting that so much new information is coming out about transthyretin amyloid cardiomyopathy and its treatment. Phil, would you like to discuss your next paper?
Thanks, Greg. The next paper that I'm going to discuss is also in JAMA. It's called Coronary Computed Tomography Angiography in Prediction of First Coronary Events, and it's by Bergström et al. From Sweden. This was a study that was designed to determine whether prediction of first coronary events could be improved by adding information on coronary atherosclerosis derived from coronary CT angiography when added to a prediction model using the pooled cohort equation, which is one of the standard approaches to risk prediction, plus coronary artery calcification score without the other aspects of the CT angiogram in that score. So this was an observational study, very large one. They enrolled people between the years 2013 and 2018, and then they followed them for coronary events for a mean of nearly 8 years. They recruited people from the general Swedish population who were aged 50 to 64 years at the outset of their enrollment, and they were invited to join a study where they would be examined at one of 6 university hospitals. 30,000 people participated, and they underwent cardiopulmonary imaging, physical exams, routine laboratory tests, questionnaires, and functional tests. The data reported in this particular paper included 25,000 people without previous cardiovascular disease and in whom the CT angiogram images were high quality and available. The main information used from the CT angiogram images was extent of coronary atherosclerosis by segment involvement score, presence of non-calcified atherosclerosis, and presence of coronary stenosis greater than or equal to 50%. Main endpoint was a composite of first occurrence of non-fatal myocardial infarction or death from coronary heart disease. During the nearly 8-year follow-up, there were only 304 coronary events, which means that this is a very low-risk population out of 25,000 people followed for nearly 8 years. All of the measures of coronary atherosclerosis were significantly associated with the outcome, and that included extent of atherosclerosis, presence of non-calcified atherosclerosis, and the coronary calcium score. The predictive model, the base model, which included the pooled cohort equations and the coronary calcium score, had a C statistic of 0.764. When the coronary CT angiogram-derived data were added to that model, the C statistic for risk discrimination improved slightly from 0.764 to 0.779. In this large study, that was statistically significant, but very small. They also looked at net reclassification improvement testing, which did not change very much in this low-risk population. So the authors concluded that the information on coronary atherosclerosis from the CT angiogram only modestly improved risk prediction beyond the traditional risk factors plus coronary calcium score in the identification of people at risk for coronary event and need of primary prevention. I would point out that this study provides information that's most relevant to the use of a, let's call it routine, CT angiogram in a low-risk screening population between the ages of 50 and 64, and we need additional information from other studies looking at higher-risk populations.
Thank you, Phil. Next, I'm going to present a clinical trial titled Liberal or Restrictive Postoperative Transfusion in High Cardiac Risk Patients. This is called the TOP Randomized Clinical Trial. And this is a clinical trial conducted in the Veterans Administration system in 1,400 patients who were undergoing major vascular surgery or general surgical operations. And the patients were at high cardiovascular risk. Postoperatively, they all developed anemia and required transfusion. And the purpose of this clinical trial was to compare a so-called liberal strategy for transfusion with a restrictive strategy for transfusion. The liberal strategy involved a transfusion trigger at a hemoglobin level of less than 10 grams per deciliter, whereas the restrictive transfusion strategy had a trigger of hemoglobin level less than 7 grams per deciliter. The primary endpoint was a composite of all-cause death, myocardial infarction, coronary revascularization, acute renal failure, or ischemic stroke at a time point of 90 days after randomization. And the authors found that there was no difference in the primary endpoint between the restrictive strategy and the liberal strategy for transfusion. Liberal and restrictive strategies for transfusion have now been studied in a number of clinical contexts, and it was of particular interest to study these two approaches to transfusion in these very high-risk, fragile patients undergoing vascular and general surgery. So we now have an answer to this important clinical question that neither strategy provided a particular advantage over the other in terms of this composite primary endpoint. And Bob, would you like to present our last study?
Oh, thank you, Greg. Among the several other papers that we are presenting simultaneously at AHA, the one that I think is worth highlighting is the manuscript by Flynn and co-authors, emanating again out of the Broad Institute with co-authors from the Massachusetts General Hospital and Brigham and Women's Hospital. They were investigating the association of clonal hematopoiesis and incident heart failure. There's been increasing interest in the cardiovascular community of clonal hematopoiesis of indeterminate potential, or CHIP, where one gets a clone of hematopoietic cells that circulate and may be inflammatory drivers. It's been associated with incident coronary artery disease and stroke, other atherosclerotic phenomenon, and also with incident heart failure. And so the finding in this study that the CHIP is associated with heart failure is not novel, but what is novel is the magnitude of the database. These investigators looked at almost 420,000 participants in the UK Biobank between 2006 and 2010 who were followed up by 2020 with a median follow-up of 11 years. And so the size of this study allowed them to dig into the subtypes involved because they were able to look at CHIP variant subtypes. And that, we think, is the new finding here, that although the predominant subtype of CHIP, which is called DNMT3A, has not been found to be associated with heart failure, the subtypes are, and these investigators were able to dig into the various subtypes, including a variant called JAK2. And in addition, even genetic repair genes were associated with the incident heart failure. Heart failure occurred in these individuals only at an incidence rate of 1.7%, which we thought was quite low. But this is a young population of 56, and the heart failure incidence was adjusted for cardiovascular risk factors. And they also excluded any individuals who had diabetes, chronic kidney disease, or coronary artery disease. And the other novel finding was that the incidence of heart failure in this group did not occur after the incidence of other things that CHIP can cause, such as coronary disease, chronic kidney disease, and type 2 diabetes. And so once they adjusted for the new onset of coronary disease, kidney disease, and type 2 diabetes, that was only related to the incidence of heart failure in 28%. So about 70% of the new incidence of heart failure was not explained by the other comorbidities that CHIP is known to be associated with. So we thought this was interesting new insights into heart failure and CHIP. And one of the other reasons for highlighting this is we have a spectacular editorial commentary from our colleagues in Spain, Dr. Domingo Pascual Fegal and Jose Fuster, who are experts in this field and really lay out for the readers of this piece why this is such a new, interesting, and novel set of data.
Well, I want to give a special thanks to our co-hosts for this podcast, Dr. Bob Bonow and Dr. Phil Greenland. And thanks to all of our listeners for tuning in to hear the research that JAMA and JAMA Cardiology published and that was presented at the American Heart Association Scientific Sessions this year. Again, I'm JAMA Executive Editor, Dr. Greg Curfman. This episode was produced by Dr. Krista Roberts and Shelley Steffens at the JAMA Network. A link to this JAMA American Heart Association content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.